Welcome to our presentation on adaptive scuba diving, operational protocols, and risk management. This session is designed as a practical reference guide for instructional adaptation and qualification management for divers with complex medical and developmental conditions. Everything we cover today has been distilled from live workshop case studies and is specifically designed for your immediate poolside application. At the heart of adaptive scuba is the balance between empathetic communication and rigorous risk management. Our guiding philosophy is that we adapt the environment, not the diver, and we do not give up until the student gives up. Instructors must apply the chisel as a screwdriver rule. Standard WRSTC or PADI medical forms are built for perfectly healthy individuals, meaning for adaptive divers, they are merely legal starting points rather than operational guides. We must also remember that behavior is communication. Resistance or panic, such as screaming at a mask, is not necessarily a refusal to dive, but rather a reaction to new stimuli requiring a methodological shift. Ultimately, our operational goal is progress over pacing. Mastering a single skill like regulator removal may take 3 years, and we prioritize progression rather than adherence to a standard curriculum timeline. Relying solely on standard forms creates a massive assessment gap. Stage 1 is the standard medical form, which acts as the legal baseline, but is functionally insufficient because it often yields uselessly broad data, like simply ticking yes to neurological conditions. Stage 2 is the GP sign-off, which is a mandatory medical baseline that transfers liability, but it remains incomplete because general practitioners rarely understand hyperbaric environments or scuba functional requirements. To bridge this gap, Stage 3 introduces a first contact interview to establish a functional baseline through deep dive questioning, such as assessing if a recent amputee's wounds are fully healed or identifying their specific daily mobility aids. Finally, Stage 4 is the operational reality, consisting of continuous poolside review by instructors and support divers. The critical realization here is that a standard 12-month clearance is a dangerous myth for progressive conditions. When evaluating our divers, we must categorize their condition diagnostics into static versus progressive trajectories. Static conditions such as amputations or physical trauma have a fixed profile where the adaptations we establish early on will remain reliable. Our key focus here is on equipment modifications, mobility logistics like hoist usage, and psychological factors, including PTSD triggers. Conversely, progressive neurological conditions like Charcot-Marie-Tooth syndrome or MS degrade over time, leading to muscle wastage, loss of sensation, and increased respiratory fatigue. For these divers, the key focus is constant reevaluation. A skill achieved 6 months ago may now be physically impossible, requiring us to internally overwrite the standard 12-month medical clearance with session-by-session reviews. One of the most severe hidden risks for individuals with progressive conditions is skin integrity and lower limb damage. Divers with MS or Charcot-Marie-Tooth often lack lower limb sensation and suffer from poor circulation, meaning that dragging their feet on a pool floor can cause microabrasions that lead to cellulitis, ulceration, and severe amputation risks. Our operational directives mandate the use of neoprene socks or booties for protection, even if the diver cannot use fins for propulsion. Furthermore, support divers must position themselves to swim parallel or above the beneficiary, and never behind them, as walking over a diver's numb feet with fins causes severe blunt trauma that the diver will not notice. If a diver refuses to wear booties, the override protocol requires the instructor to either document the refusal or completely decline the dive. Cognitive and neurodivergent adaptations. When working with cognitive and neurodivergent divers, we focus on sensory management, behavioral cues, and structural consistency. To manage sensory input, instructors should dim pool lighting if possible, and conduct briefings in quiet rooms separated from the chaotic pool decks. We also recommend olfactory preparation, known as the chlorine walk-in, where the student walks onto the pool deck to experience the smell, leaves to process it, and then returns to kit up. Instructors must watch for subtle behavioral cues. A lack of eye contact does not mean a lack of attention, and anxiety indicators may manifest as non-standard distress signals, like excessive yawning or sudden tics. Crucially, we must maintain structural consistency by keeping rigid, predictable session structures and avoiding sudden changes or improvising new skills mid-dive. To bypass psychological resistance in the water, we have two primary methods. If a student falls into an anticipatory anxiety loop and freezes when asked to submerge, we use the countdown method. By using a rigid, predictable countdown like, we're going underwater on 5, 4, 3, 2, 1, we remove the burden of initiating the action from the student. Alternatively, if a student experiences a direct demand block and treats face-to-face commands as a confrontation, we use the indirect method. Here, the instructor stops making demands, swims alongside the student to establish parallel movement, and casually taps or signals the skill mid-swim. This removes the pressure of direct focus, and the student will often instinctively mimic the action. For visually impaired divers, sensory deprivation protocols are executed in 3 phases. Phase 1 is pre-session audio anchoring, where we provide audio files of skill briefings and tactile hand signals for home study, which builds cognitive familiarity before they encounter the overwhelming sensory environment of the pool. Phase 2 occurs poolside and focuses on tactile orientation, allowing the diver to physically map their own kit independently while conducting dry runs of tactile signals on their arm at the surface. Phase 3 covers entry and the environment. We avoid deep water giant strides initially in favor of shallow water walk-ins, and we must provide rich audio descriptions of the pool's dimensions and depth profiles before submerging. Once underwater with a visually impaired diver, the mechanics of continuous tactile communication are critical. The foundational principle is that for a blind diver, a sudden grab underwater feels like an attack, meaning communication must be continuous and predictable. You must use the sliding method, maintain light, continuous physical contact, such as holding a BCD strap, and when initiating a signal, slide your hand down the diver's arm to the wrist before giving the tactile squeeze. This provides a physical heads-up. You must absolutely avoid the broken contact method. Never release the diver, swim away, and then suddenly grab their arm or shoulder, as this causes immediate startle responses and respiratory spikes. When managing type 1 diabetes, the primary threat is diabetic unawareness, where blood sugar can crash in minutes, and divers may not realize they are dropping until they lose coordination or suffer convulsions. We operate within a 5-minute emergency abort window. As a hard limit rule of thumb, divers must maintain a depth and profile where a total dive abort and surface return can be executed safely within 5 minutes, usually capping max depth between 1.2 to 5 meters, depending on the protocol. Instructors must also be wary of the technology trap. Continuous glucose monitors are not pressure tested and can flood or fail at depth, while insulin pumps are highly dangerous because pressure can cause them to malfunction and deliver a fatal insulin overdose underwater. In the event of a hypoglycemic attack, fine motor skills and cognitive function degrade rapidly, making equipment modification vital. The wrong way to store emergency sugar is in a zippered BCD pocket with thick gloves, which practically guarantees the glucose tube will be dropped and lost. The right way is the quick draw setup. Store liquid glucose gel tubes in a transparent pouch clipped directly to the upper chest D-ring. This ensures immediate, gross motor access, allowing the gel to be squeezed directly into the cheek or mouth for rapid sublingual absorption, without the diver needing to fully remove their regulator. For divers who have experienced physical trauma or amputations, we look at both hardware modifications and psychological adaptation. Hardware modifications often cater to unilateral dominance. For example, if a diver has an injured right arm, we reroute inflator hoses, alternate air source necklaces, and weight belt releases entirely to their functioning left side. For propulsion, if leg stumps cannot utilize specialized adaptive fins, we utilize webbed gloves for arm swimming. Psychologically, we must be aware of the balloon test analogy, particularly with combat veterans who may carry undisclosed PTSD, as sudden loud noises like dropped tanks or popped O-rings can trigger severe flashbacks. Above all, we must prioritize their agency by allowing maximum independence during kitting up, such as edge sitting instead of hoist usage, to preserve the diver's dignity and control. Our duty of care extends beyond the water through operational logistics and safeguarding boundaries. We strictly enforce the rule of two in changing rooms for vulnerable adults, such as visually impaired or cognitively delayed divers who require assistance navigating the space. It is an absolute rule that staff must never enter a changing area one-on-one with a vulnerable beneficiary. A minimum of 2 staff members must be present to prevent any allegations of impropriety. Additionally, we maintain a transit duty of care, recognizing that our responsibility does not end at the pool edge. Visually impaired or vulnerable divers must be physically escorted to their specific exit point or pre-booked transit to ensure complete chain of custody safety. This master adaptive diagnostic matrix summarizes our core strategies. For progressive neurological conditions, the primary risks are skin integrity and hypothermia, requiring standard communication but mandatory booties and limited dive times. For neurodivergent individuals facing sensory overload, we use countdowns and indirect instruction, paired with dimmed lights and isolated briefings. Sensory visual impairments present the risk of startle panics, which we mitigate with continuous tactile contact, audio files, and dedicated one-on-one support divers. Finally, metabolic conditions, like type 1 diabetes, carry the risk of hypoglycemic unawareness, demanding pre-dive sugar checks and chest-mounted glucose pouches. Finally, we must discuss qualification ethics and the burden of certification. Scuba agencies award lifelong, global certifications, creating a dilemma. An adaptive diver holding a mainstream standard certification presents a lethal risk if they attempt to dive in open conditions without specialized support, because they cannot self-rescue globally. To manage this, we rely on the local adaptive network, utilizing local dive clubs and restricted certifications to keep vulnerable divers under professional supervision. The golden rule of adaptive diving is this: adapt the instructional method endlessly, but never compromise the safety standard.